Welcome to our OMTech Keynote webinar. I'm Carolyn Lowell with OMTech, and I want to thank you for joining us for this important discussion on preparing for the shifts in procedures to the outpatient setting. This morning, we've assembled a panel of diverse perspectives to provide you greater insight as you develop your own internal strategies that respond to the growth of the ASC market. This is the second of two live keynotes that we're hosting. While we were unfortunately, we were not able to hold OMTech in person this year, we felt it was important to maintain the robust education that OMTech attendees are accustomed to. So in addition to this keynote, we've developed 25 on-demand webinars that address today's critical topics, from orthopedic market forecast to product development to the regulatory landscape. And the education is complimentary on the OMTech website. And if you missed our keynote yesterday with executives from Medtronic, Microport, Paragon 28, that keynote, as well as this one, will be available for you to view on the OMTech website next week. Our sponsor for today's keynote is Tecomet. Tecomet specializes in forged, cast, and machined orthopedic implants, instruments, sterilization cases, trays, and photochemical etched products. The company also offers innovative product development solutions through its Tecomet Standard Products, Launch Quick Process Development Centers, and its Total Solutions philosophy. Tecomet manages every detail of the product launch cycle, allowing them to provide device companies an exceptional customer experience. So thank you to Tecomet. We appreciate your sponsorship of this keynote. Now to introduce our speakers. Our moderator is Patrick Vega. Patrick is a consulting director at Vizient Advisory Solutions, where he assists musculoskeletal providers with aligning their cost, quality, and performance. And he is joined today by four panelists. Dr. Robert Bray is a neurological spine surgeon, and he is also CEO and founding director of Disc Sports and Spine Center. Laura Rector is Vice President of Ambulatory Surgery Centers, overseeing strategy and development for Smith & Nephew. Ryota Terada is Director of Orthopedic Intelligence and Payment and Policy with SG2 Healthcare Intelligence. And his colleague, Kate Zentner, Director of Neuroscience Intelligence, is also joining us. We will hold an audience Q&A at the end of the discussion. As questions come to mind, please use the Q&A field in Zoom to submit your questions. And with that, I would like to ask our panel to turn on their cameras and unmute themselves. And Patrick, I will hand it over to you.
Thank you very much, Carolyn. I really appreciate it. Appreciate the panelists making some time to talk with us today. We've had the opportunity to talk a couple times with them, and I think we have some very exciting and insightful comment to share with everybody. So with that, let's start the first theme, our discussion of the first theme today. And I'd like to start with Dr. Bray. And the questions are, what procedures are now common in ambulatory settings, and what procedures are out on the leading edge and anticipated to become more common? First question. Second question is, what are the main elements that have driven the growth of the practice and volumes in the ambulatory setting? Dr. Bray.
Thank you for having me. The ASC has been an amazing growth market, and I started 22 years ago developing outpatient. What we did is we divided up our cases into simple, complex, and super complex. And the interesting thing is, in the last couple of years, our biggest growth has been in the complicated or the difficult cases. For us, the complex and super complex include the multi-level ACDFs versus arthroplasty, the lateral fusions, the front and back, doing vascular access with front and back. We've seen in the last year during COVID, 100% growth in this year of our spine center. In the first quarter this year, another 30% growth. Most of that growth for us has been the development of the arthroplasty and the fusion market from the ALIF and lateral. The main drivers that I've seen are we've developed a completely in-network model with insurance companies. We've actually transitioned that and even gone to a global billing model where we're billed all together. And that plays into our relationship with the vendors significantly, because we're on a a global fee and the time and materials, they need to become a partner in that total pricing. That and COVID. COVID has fueled our growth. People have been afraid of the hospitals, and it's been very important for the ASCs to tell their story. We've been up and functional and safe and haven't had a single case transmitted internally. A lot of protocols, a lot of development and management. We cut out pain management and high contact things in the early phase to concentrate on spine and high acuity ortho, but our growth there has really been unprecedented. We're having our biggest issues are keeping up with staff and getting new people up and running. But the growth, we stand at 130% growth since the beginning of COVID.
Very good. Dr. Bray, would you briefly describe DISC, the longevity of it, the number of locations, the typical procedures you're performing there, and a little bit about the business?
So DISC, or Diagnostic and Interventional Spine Care and Sports Care, started 22 years ago when I moved out of Cedars-Sinai, where I ran the spine program inpatient. And we began in Marina Del Rey 10 years ago. I came to Newport Beach. We're in the process of building a new one in LA now to update. We started with focused on spine, and that has been our major focus, although we do a full gamut of sports medicine, take care of all the Red Bull athletes for the world. So we do a lot of sports medicine, but the major emphasis has been spine. We started historically with as many places do, with micro discs and decompressions and simple cases, but it's been a growth and a transition. And we really now do, we have 24-hour care, overnight stay. We do full complexity of all spine cases, short of full segment scoliosis. We do short segment corrections, but front and backs, complex neck, we do tumors. So we're a full spectrum spine facility. And the whole processes, procedures, the how to do that, and the contracting, the development is all been about transitioning to develop that complex cases. I think DISC has really led the way in developing the world of high acuity outpatient medicine.
Thank you. Laura, on behalf of Smith & Nephew, could you please provide an overview of Smith & Nephew's commitment to the ambulatory space? And then the second question, where in your business are you seeing the most growth from an ASC perspective? And that could include geographies, products, services. Laura.
Sure. If you don't mind, I'll answer the second part of your question first, and then the first part second. We're seeing growth in actually all parts of our business. So Smith & Nephew has franchises dedicated to sports medicine, orthopedics, and recon, hips and knees. And also we have a wound business and a robotics business. So all of these products are highly applicable in the ASC setting. And we're seeing growth in all, but none more than the recon business, with hips and knees now being able to be performed in the ambulatory care center. As far as how we're committing, what we're doing, we are all in for supporting the ambulatory surgery centers and the surgeons that take their cases there. There's this huge wave of migration of cases, which I'm sure the folks from SG2 will talk about, that's happening right now. And we feel like it's an opportunity to help our physicians make that leap from the hospital to the ASC. There's a lot of needs, a lot of pain points when you leave the hospital and go either start your own ASC or go to an ASC. And wherever there's pain, I always feel like there's an opportunity for companies like Smith & Nephew to support their customers in new ways. So about 2 years ago, Smith & Nephew really committed with a full dedicated team of people. So people, programs, and resources. We've dedicated and invested in 3 acquisitions to develop a digital health patient care management platform for the ASCs to be able to utilize to be more efficient, productive, to change the whole care experience for the ASC patient. And then the last part is partnerships. There are a lot of things that we don't do as Smith & Nephew, but our partners in the industry do really, really well. So we spent the last 2 years making a lot of really well-connected relationships and formal partnerships with companies like National Medical Billing Services, because they do something really, really exceptional that we don't do, but that our customers in the ASC do need. So we have a relationship with them and others that provide services that will help physicians and centers function more efficiently, but also to support them in new ways.
Great. Thank you very much. And I know we'll come back to some of the detail on what you're providing. Let me pivot to Kate and Ryota. Both of you, can you please describe the growth and landscape of ambulatory services?
Certainly, Patrick, and thanks so much for inviting us to this conversation, Carol and Patrick. Really great to be joining. Lots of factors accelerating the ambulatory shift across the board, but really want to keep in mind that this is very market specific. That said, as Dr. Bray has described really well, one impact that cuts across markets is that the response to the COVID-19 pandemic has dramatically accelerated reduction in length of stay and shift to outpatient status, thereby setting a stage for a faster ambulatory shift in the coming years, even in markets that may have not previously seen a shift of complex cases to the ASCs. But before getting into the market-specific details, Kate, what are you seeing across the country?
Sure, Ryota. We're still hearing that some of our members aren't necessarily where they were in terms of volumes previously, but for the most part, now we're really looking more towards growth strategies, and ambulatory shift certainly has to be a big part of that equation. When we think about orthopedics and spine in particular, we know that we already have a pretty substantial portion of procedures nationally that are happening in an ASC. Even pre-pandemic 2019, maybe around a third or so of ortho and spine procedures were happening in that setting. Maybe a little bit less for spine, a little bit more for orthopedics, but that is all sort of poised to change. I think in the past, really arthroscopies, pain procedures, carpal tunnels. It was really those sorts of volumes that were driving a lot of what we saw in an ASC. But with all of these pressures merging, kind of care redesign, sort of innovators like Dr. Bray's organization, policy changes, a lot of things that are really sort of merging, such that now we will see that bigger shift occurring in areas that are more complicated. The fusions, the total joint replacements for elective cases where we have quite a bit more room to shift. And some of these things were maybe less than 10% or so nationally done in an ASC previously. All of that is going to be changing, but as Ryota mentioned, a lot of this is going to be very procedure specific. The extent and timing, really, all kind of about staging, really going to differ by market.
Great, thank you. So a follow-up question, in what ways does this shift vary by market? Because I know in the number of conversations that we've had, that's something that a theme that you come back to continually. It's very market specific. So can you comment, Kate and Ryota?
Yeah, certainly, Patrick. So when we're speaking about that market level variation, we're really thinking about a combination of interplaying factors that act as brakes or accelerators, specifically thinking through, for example, even federal, state, or local regulations. So from federal side, whether there's CMS policy changes or state level certificate need restrictions on new ASCs being built, to local or specific ones, as well as thinking about the overnight stays, to how long you can stay in ASC, to maybe procedure specific waivers that are required, thinking about Pennsylvania waivers for total joint replacement. And as Dr. Bate mentioned, getting enough staff that can do this, getting them up to speed, thinking about restrictions for your patient population. Can they really be safely discharged at home? Maybe they're going back to a 6-floor walk-up in New York City, for example. To then thinking about the competitive landscape, what may be pushing that shift, what may be actually making it so you don't have to shift immediately. And perhaps most importantly to all this, and I'm sure Dr. Bray can go into this all in more depth than I can, is the physician comfort, acceptance, and leadership that can impact the pace of shift quite a bit, and what procedures they're comfortable with shifting as well. Now, as an example of what we're seeing in terms of variation, certainly we've talked a lot about kind of that spine growth that Dr. Bray's been seeing, but in orthopedics, according to SG2 commercial claims data, markets or states really such as Indiana or Colorado leading the shift are already performing over 30% of their markets' commercial joint replacement cases in an ASC, while many other states' markets are still in the single digits. And the outpatient shift today for complex procedures has primarily been a change of status due to length of stay reduction and policy changes, rather than maybe moving out of hospital-based settings quite yet.
Kate, did you not add any comments to that?
Ryota hit it. I mean, it's been so variable, right? And I think it was interesting to see over the last year in some markets that were prepared for it, obviously, that ASC shift happened, really, really quickly because they were able to really kind of lean on that, right? But other markets, we heard kind of, some organizations saying, okay, well, maybe we can shift patients there, they'll feel safer. But if they didn't have the infrastructure to do it, obviously you can't turn it on overnight. And so I think that's led to some of the differences, of course, that we've seen, but certainly something that health systems aren't thinking about this. Other providers aren't thinking about it. They're probably a little bit late to the game and need to get on board now.
Mm-hmm.
Right. Okay. Thank you. Dr. Bray, a couple questions for you. What clinical and procedural breakthroughs are fueling ambulatory growth, and how will robotics fit into the ambulatory setting?
Interestingly, diverse questions, but the breakthrough for what we've seen in the ASC has been a time learning curve on the development of patient management, where we have learned that early mobilization, very close management of their pain. It's much easier if you don't let a person get into pain rather than have to get them out of pain. So tight management of their pain management problems, and interestingly, management of their urologic conditions. Those are the medical keys that have really led us to move forward. We've been really enjoyed in the last 5 years. We've never had a single hospital readmission after discharge. And that really says to the nursing staff and the education and the control of all those parameters, because people just aren't out of control. The biggest clinical for us has been that the development of what we call minimally invasive. I think it's an overused marketing term, but it's a philosophy of how you handle the procedure, from the choice of the procedure, how you handle the tissues. We're a very microscope-driven facility, most everyone, or at the very minimum, high-powered loops. The sets from the companies need to be rethought for us. My instruments are this long, not the long ones they see, and the sets really weren't designed for this environment. So from the company point of view, we've been working with them extensively, trying to redesign things to fit our environment. Smaller sets, less bulk on our SPD, better fitting for the procedures we do. But it's been the microscope, things such as percutaneous screws and all of the techniques that allow us to be less invasive. Those things all result in a better quality outcome and a happier patient. And I think that also is the driver that we're really seeing, is that now we are moving into an era of big data, that data is going to be driven for procedures. People are going to look at cost, quality, patient satisfaction, outcome, patient-derived data. They're going to loop it back together, and it's going to become centers of excellence that follow these protocols. So we need to look to all these things very carefully. And as we show these procedures, we've been benchmarking against every national benchmark and showing that in the ASC world, the numbers are coming out better. The cost is lower, the quality is up, the complications are down. And if you can show that data and prove that data, that's how we're going to lead to the growth. The companies need to participate in this curve, though, which is development of things for us.
Great. Can you make a comment about robotics? Is it part of your center now? Do you anticipate that it will continue to grow if it is part now?
So robotics have two different places in orthopedics versus spine. And in spine, they're more limited at the moment. We think of things in terms of navigation and in terms of robotics for an assistant to hold an arm or hold a retractor, and decrease personnel around the table. And they definitely have a place there. The navigation systems are really more for scoliosis and those bigger cases that are going to stay at the hospital for a while. We're probably behind the country in moving total joint in California to an outpatient world, where other places have led more, but certainly the robotics will take a place there as that happens. Our new center we're building now is taking into account to build total joint. So we'll be selecting our robots there. So it's a mixed market for the robots.
Great, thank you. Laura, how big is the sales opportunity in ambulatory surgery for device and manufacturers. And with physicians now being business owners, in addition to products, should vendors be offering complete solutions such as billing, administrative, or marketing support? And then would you also please comment on robotics?
Sure. So for the short answer for your first question is the market is doubling in size. I mean, it's just growing rapidly for a whole host of reasons. There are about a little more than 1 million procedures, hips and knees being done right now in the United States. And within the next 3 to 5 years, it's going to be 2 million, 2 million plus. A lot of factors there, the aging baby boomers who've exercised, from a very young age and are wearing out their joints faster and all kinds of things. So we see it as a huge opportunity, which is why we've dedicated a whole team to it. And also why we've made acquisitions in key areas that we think are pretty critical for the growth and the support of the ASC customer around digital health and patient care management and remote home PT care. One of the things that Dr. Bray said that really resonated as well is I mentioned we're investing in a lot of ways in the ASC specifically, but for products to ASCs are stretched in their SBD units, how to turn cases faster, create more efficiencies. And we spend a lot of time and effort in R&D and research on how to get cases from 10 trays or 12 trays down to 2 trays so that our customers don't have to manage all of that equipment. Number one, they don't have the space for it. Number two, it doesn't have to be reprocessed and take all that time to reset for the next case. So we have some really advanced technologies on our recon side, our sports side that allow for that to provide relief and efficiencies that I'd mentioned a little bit earlier. I do believe wholly, and my whole division that's called Positive Connections is being built out specifically to do everything for a customer, patients, for payers, for surgeons, for owner operators. That has nothing to do with the traditional recon products. That's the whole other side of the Smith & Nephew business. Positive Connections, we say, is everything beyond that product. We make world-class products. We do world-class training at Smith & Nephew, but Positive Connections, the ASC team, is doing all of the other things. So yes, if we don't invest in it and a technology, we will partner with the best in the business that do what is needed. You mentioned specifically billing. That is a really important thing to help improve cash flow in an ASC, super important. So we started one of our first partnerships I mentioned already with National Medical Billing to help support our customers in that way. But we're doing other things, like, for example, how do you get a patient to be more compliant on their physical therapy? How do you care for patients who are in remote locations who come to your city for surgery and then leave, and make sure that they're getting the best care? Smith & Nephew's committed to something we call Life Unlimited, getting our patients back to Life Unlimited. And how do you do that? After surgery, there's some steps that need to be taken for a patient to be able to get back to whatever it is they like doing, swimming, golfing, whatever. So our remote PT product, which we invested in and purchased about a year ago, just launched here in May 5th, we think is a remarkable step forward for an orthopedic company to be looking outside of that implant box about how do we really commit to the Life Unlimited concept and not just sell an implant. So that's one thing. So yes, I full-heartedly believe that my whole franchise is committed to the notion of doing everything we can to support our customers in new and different ways, but in meaningful and necessary ways that relieve the pain that they might have of being a business owner in the ambulatory surgery center. As far as robotics, we have a robotic solution. It's called Corey. It's a very small footprint. It's probably just a little bigger than a laptop. It's not one of these huge pieces of equipment. It doesn't cost $1 million, doesn't have this huge arm, and doesn't require CTs. It's built for the ASC. It's a very unique robotic solution and a much more affordable, but also feature rich, much more features for the ASC environment. We believe there's 2 reasons why an ASC would want to invest in robotic technology. It can help them be more efficient. and more cases can be done in a day if you have a robotic product. And then also patients are looking for ASCs to differentiate themselves with new technologies. So a lot of them are very consumer savvy, shopping an ASC, wanting to know, do you have the latest and greatest technology? So it is also a great product to have in the market that you have that technology and your surgeons do robotically assisted surgery because patients are looking for it. So I think
Wonderful. Thank you.
that probably tells you what you need to know.
Sure. Thank you very much. Back to Dr. Bray. So I want to solicit our panelists here in terms of what advisement would you offer to a manufacturer, a supplier, relative to their products, your needs, that they might not have insight today. Dr. Bray?
Well, I would thank you, Laura, for your comments, because they bounce right back. I think that really the first advice I have is around developing the relationship at the ASC level and looking to that. Over the years and years past, the relationship has been the rep to the surgeon, and the surgeon going wherever, and things were sold to the surgeon to choose what they wanted, or even with upsales in the OR. None of that's going to exist in the ASC. We function under a model for one rep for one product, and different reps can't come in. We have one person who does it. It's too complicated for us to go to multiple different locations. But the relationship is with the company to the ASC, and that includes everything, as she was saying so aptly, from the billing to the pricing, from the delivery and schedule to dealing with our SPD differences on timing of delivery. We can't get a tray of instruments in the night before. We don't have any night staff to process it. It doesn't exist for us. So, developing that relationship and working with us on the things we need. The billing cycle is important. How is our billing cycle running? How is that held to the company? But we need to develop that direct, and the companies do need to realize that the ASC is the customer, and it's going to be expanding, and the market is going to be maybe 30% now. It's going to be exceeding the majority over the next 4 or 5 years to come. I think that rethinking of the role of the contact person that we deal with is also critical. We need a direct line of access to the company corporate for answering and developing a lot of these questions, not just our rep. I see things changing as less of a rep on-site delivery model and more of a training program that comes in, where the corporate comes in and brings in both their training to people for all these other business questions that, frankly, historically, the doctors have not been as good at, and helping develop partnerships for those pieces, but developing that, and then with the on-site, after an implant system is up and running and taught, we don't need the rep here every time anymore. Then we need more of a restock, seamless way to get the new equipment in, turn it over, bring it in. So I think a rethinking of the model of how the delivery is happening is going to be critical. And that's going to lead us to better cost efficiency, because, thinking back to the big picture, we're on time and materials. We have to be efficient. That's what the payers are doing, and they're going to drive the cases. I'm seeing the payers now drive me cases. They're putting us as the number one referral source of their website. They're actually encouraging new doctors to come and contact us to join, to bring cases. We have all types of programs that are developing that direct from the payer as well as the customer. And what Laura was saying, absolutely, the customers are very savvy, and that has all changed in the internet, and the amount of data available is tremendously different than it was years ago. So we need to look to building that image and telling that story. And that story, the question goes back to Laura Rhoda, Kate, how do we loop all this together? Because together, as companies and representatives, we need to tell that story of what's happening at the ASC and get that information out to the customer, the patient, because they're looking for it. So the better we loop all that information together, the better we'll tackle this.
Let me supplement those comments, and thank you. Those are excellent. In the couple conversations that we've had, you have specifically said relative to suppliers and vendors, send your development team to sit down with us and talk. So 2 questions. One, could you amplify that a little bit? And then secondly, I would presume that you have a sense of how the ASC model is substantially different than the hospital and inpatient market. And what would those contrasts be? And further, what advisements would you give to the supplier and manufacturer relative to approaching this market? So I long question, send your development team was one comment, and then specifically, how is this ASC setting very, very unique?
Yes, critical topics. And first is the development of that relationship from the ASC, which ASCs are going to loop together as centers of excellence. Again, the big data is driving the payers to form consolidated relationships that will extend from payers across multiple ASCs that are linked from a data point of view. Developing the relationship straight to the corporate suite. Yes, we need to know, who do we call at the company? Who is our contact in their business development department? How do we communicate the problems to? And that team needs to come sit and meet with us or us at their corporate centers, either way. But we need to develop that relationship. And the biggest difference really is understanding our flow and our billing. And again, ASCs are on time and materials for the vast majority of them. And we've taken the next step to global billing, understanding that a front and back surgery, I get paid the exact same price no matter what I use, which biologic, which implant, how many, what levels. We've put in place standardization for our surgeons, where we have teaching pieces for our surgeons that become involved because they're owners. This is their margin or not. And that can be a or not scenario with selection of procedure and type. So looping all those things together, getting the company and their business development people to sit down and understand with our surgeons, knowing what's available from the companies at what cost points, how those will impact the case and the flow. Then meeting with I'm blessed. I have Karen Reeder, who's been in the ASC business running ASCs for 30 years now. She reminded me she's 31 years this Friday. All those processes and procedures of how we do it, from the SPD from the stocking, from the time to reimbursement to the number we're going to get to where the margins are. It's critical to know the case costing. The company should understand that. They send their people in, they should know our case costing. Where do we need to become an open relationship with them of how this market is developing, so they can understand what margins and where their future lies with this development of the ASC. And we need to work with them to know, here's a cost-efficient future, and set targets and say, we're here, we all need to be here on cost efficiency and outcome. And then the final is getting involved with that data set. Any procedure we're doing, whether it's a lateral and posterior percutaneous screws or arthroplasty versus ACDF, it all needs to be data driven, and all that data needs to get looped back together, down to efficiency, cost, down to outcome, not all independent of each other. So we need to work together on those, and it requires integration of the teams, simply put.
A quick question for you, and then we have an audience question. Laura, how will the shift to ambulatory care impact device companies from research and development and site, supply chain, and selling?
Yeah, so I'm not going to be able to take the smile off my face, Dr. Bray. Everything you just said has validated the 16 to 18-hour days for the last 2 years and the multiple investments that Smith & Nephew has made. So I need to get the recording of what you just said and listen to it every morning as an affirmation. So thank you for that. Here's what I'll tell you. We have really changed what we're doing. My whole business is focused on the ASC. And we've done a lot of research, as you mentioned, Dr. Bray, studying the outpatient center, what their needs are, and ranking them in order, and then attacking each one of the needs that you just outlined so eloquently, and preparing, doing that research, and then the development was purchasing the acquisitions to do data capture through the patient management solution that we have. It's called ARIA. So ARIA has the ability to capture PROMS data, but everything through the surgical episode all the way to the physical therapy afterwards. So you want to talk about being able to have a resource that we've developed and invested in that provides data. It's a data solution that's so big and connected through end-to-end experience with a patient, from pain to back to recovery, is already out there and working. We launched ARIA in late December. It's a patient management tool that helps with efficiencies and all of that, but along the way, it captures the really key and necessary data for a surgeon like yourself to work with payers, show them your outcomes, and negotiate out what your bundles will be. So
send your team in, because we have
I
seven new ORs in construction that are going
absolutely
up in the next year, and
we are
it's
here.
exactly what we need. So.
Yeah, no, so as you know, software solutions are kind of a work in progress, right? You're always developing, always iterating, always adding features as you learn. So where we are now is not where we'll be in 18 months, but we'd love to come share the vision of what it is, and get some help making sure we're doing the right things in the right order. Also through it, it creates efficiencies with your care navigator, because they're navigating, or they're actually assisting the patients that actually have a need, the outliers versus, all patients. Calling every single patient, the system will take care of most of your patients, but the outliers that need the attention is where your care navigator can spend their time. So it's not an exact answer to the exact question you asked, Patrick, but research and development looks different. It's not an implant and an iteration on an implant. It's actually a whole new company, a digital health company that supports our patients in so many different ways, and our surgeons, but it also supports patients. It changes the care model. It creates a whole different level of patient satisfaction and connectedness to the surgical patient, where they feel like they have a white glove, handheld experience from beginning to end of what to do, where to go. And so it also answers one of your other questions or points that you made, Dr. Bray, around, patients and patient steerage and patient acquisition. That's the number one thing we found in research with surgeons and owner operators is, can you help me get patients to my facility? We have a world-class facility, but what we need are patients to see us that way and know about us. And we need the latest and greatest technologies. And then we need those technologies to be AI enabled and learning all along, and providing us with data of how to serve them better and what our outcomes are. So that's what we're doing, Patrick. We're always looking for ways and to connect with someone like Dr. Bray, who shares the opposite side of it. We're the manufacturer vendor, but on the service side of it and the physician side of it, that can to help us bring that whole team effort, become a different kind of team member to the ultimate surgeon customer in the ASC.
In the last
exciting stuff. Very exciting.
Just to comment, in the last 3 years, we've gone from 3 surgeons to 26 surgeons using the facility. So integrating all of them into pathways and how they do it, and integrating them into contracts and integrating them into use of systems is just a paramount growth issue.
Yeah, and something tells me that's we could do a complete separate webinars just on that particular issue. Let me interrupt for a second. We have 2 audience questions, and I just make this open to the panel. First question is, how will the shift to ASCs play out in more remote, rural areas of the country? Will patients need to travel longer distances to seek care? And I invite anybody to respond to that.
Yeah, if I may at least kick this off, I think it's a really interesting question, because I think a lot of the focus and where we see the leading organizations are usually more in urban areas, or maybe there's a nexus of a large physician group that has the appetite to lead this shift versus maybe in more and truly remote and rural areas. Really maintaining even the access to complex surgeries is probably paramount to sort of community in the first place, let alone even shifting to ASC. So one thing to keep in mind here is that even commercial payer policies that are actively steering patients to ASCs, they have exceptions such as geographic access considerations. So where they draw the line on that certainly would matter in terms of how that will influence how long patients will have to travel. But in truly remote areas, I wouldn't necessarily be concerned from the patient perspective that this will force you to travel longer. Now, the wild card though is if this does have an impact on, say, critical access hospitals or small community hospitals in rural areas, for them to be able to continue providing services to their market because they're seeing kind of shift, especially of the commercial patients to ASCs, maybe out of their market. That is something that may require additional government support or really them rethinking how do they operate their business so that they can maintain really access to care in their markets.
A lot of surgeons have traveling programs, but their biggest concern is what happens when they go home. And that's why we invested in the ARIA Home PT product, which is set up and in their home and waiting for them when they get back from wherever they've had surgery back to their remote location. And all they have to do is push a button and they can start their PT where they are in their home on their own time. So it takes care of that concern and that issue of, well, how will they recover if they're not here and I can't see them? And so they can do telehealth visits. They have a PT in their home. They do it on their own time and in their own location. And right now there's a pretty big shortage of physical therapists, especially access to care in remote and rural areas, which this device allows patients to now have that same quality of PT wherever they are. So it's pretty exciting. It's really easy. Literally plug it in, push a button, and it has a net promoter score of higher than an Apple phone. So better usability and functionality and friendliness to a patient. So I'd say that's going to lead the way for more travel programs because it alleviates this concern.
Dr. Brady, do you have a comment?
Yeah, one of the things I would throw in here is to not necessarily differentiate too much that this is all ASC. And when you talk about rural hospitals, them developing the same type of protocols we're talking about for development of the ASC and carrying that to their rural hospital, maybe as a hospital outpatient department, but the same processes, procedures, handling, implementation, duplicating this whole structure to have it duplicable and replicable and teaching to the physicians. People think of California as, LA and San Diego and San Francisco. Let me tell you, there's a lot of California that's rural, that's inland. And I have surgeons that work here several days a week who drive way into the Inland Empire and do a day a week in there at a small hospital. They're taking what they've learned here on how those procedures are handled and driven and taking it to those places. So I wouldn't just differentiate it as an ASC. I would think of it more as a model which can be replicated, which spans everything from the company to the things Laura was talking about, to the payer mix, to the billing, to the cycle, to the delivery, to the whole piece. And it's this new process and thinking that is going to drive the data and drive the outcomes and be very applicable to driving business ASC, but it's going to make it more replicable to take it to a broader environment. And that's just the key I think we have to maintain.
Let me hop in. We're looking at 15 minutes to finish. I have 3 questions and they all generally go in your direction, Dr. Bray. So if you could just give a brief answer, because I know we're going to end up potentially running short on time. I want to make sure we get to these. So how is the shift to outpatient going to impact medical education? Do or will ASCs have residents? Just a quick comment, if you would.
Yeah, absolutely. We'll have residents, not necessarily residents, probably more fellows for spine, possibly orthopedic residents coming in, but we will be looped into teaching structures, and there's going to be relationships built between the established teaching structures in the outpatient world, because it has to be taught to the future surgeons.
Great. Okay. Second question for you, Dr. Bray. What's the number one pain point for ASCs, specifically for disc?
The number one
pain point. Number one pain point for ASCs.
pain point?
Yes. What's
the most difficult thing for us? The challenge, education and staffing is our biggest thing, and both getting the nurses and retraining them to this whole new process of thinking of how we're mobilizing and treating the patients. I think it's the biggest issues for growth or staffing.
Okay, very good. So let me pitch this to both you, Dr. Bray, and Laura, if you have a comment as well. So from a surgeon's perspective, do you see disposable instrumentation replacing the traditional sterile sets that are continually reprocessed? And how much of a quality difference are you willing to give up to make a change to disposable instrumentation? Real brief questions, because there's, answers, because there's a couple more questions I want to get to.
Great question. I see disposables and prepackaged coming into play for sure with pieces that drive the implant in. I honestly do not see it coming in our use instrumentation, like our biting and drilling and things, disposable drills, obviously, but because the quality there, we can't sacrifice, but on a lot of the sets to drive those sets smaller and less SPD, it definitely is going into play. It's not a big sacrifice in quality either.
Laura, quick comment?
No, I concur completely. Yep.
Okay, very good. Let me shift to payer and policy issues. Kate and Ryota, how will payment and policy impact reimbursement in the ASC? CMS proposes removal of all MSK procedures from the inpatient only list in 2021, and they proposed to add hundreds of procedures to the ASC covered list. Quick comment from each of you on those.
Yeah, I think the one thing to keep in mind is the difference in approach between what CMS is doing versus maybe commercial payers and employers are leveraging. So from CMS, it's really removing restrictions on where care can be delivered, putting the decision more on providers and clinicians on where it can be delivered. Particularly, say the ASC covered procedure list that just changed. CMS is taking a step back from deciding whether cases are safe to be performed in ASC. They're just saying that we're going to cover it. Here's the price points for it. And the clinician can decide whether it's safe or not. That's a big change. Now, for commercial payers, though, we're seeing more of an active steer. So Dr. Bray mentioned, steering to disc, but also even in what is paid for, they have site of care restrictions that are increasingly expanding. So United Healthcare and some Blues, they're dictating where care must be delivered, ASC versus hospital-based setting, sometimes even office for lower complexity cases. Think about your sports medicine, arthroscopy, something like that. Unless there's exceptions like the clinical outcomes, the geographic access I mentioned before, or impacting patient choice of surgeons. But Kate, anything else that you're tracking?
So there's one more development. Starting July 1st, CMS is actually adding to the list of prior authorization, where if you're doing procedures in the hospital outpatient setting, you'll have to get prior auth. Cervical fusion with a discectomy, as well as pain stimulators. So it's not as forceful as those site of care restriction lists that commercial payers have in place, but it is sort of raising the discussion that on one hand, I know there's some professional societies really worried that complex pain patients are already challenging enough. So why are we throwing up additional barriers there? But for some patients, the path of least resistance might be the ambulatory surgery center. So we could see it pushing a little bit more that way for patients where that is a good fit. So some different pushes and pulls.
Very good, very good. So let me talk about the surgeon supplier vendor relationship. So Laura, there was this 2019 Bain & Company article on ASC growth stated that 60% of ASC physicians would purchase a similar device from a different manufacturer if it were offered at a 15% discount. And I want to couple that with something that you had said in a previous conversation, which was historically the surgeon vendor representative relationship was central to servicing physicians and hospitals. In the ambulatory setting, has this changed? And if so, how?
Yeah, I think it follows the conversation that Dr. Bray was saying, that he needs someone, a person that focuses on other things besides, for us, it would be the implant, right? On some more of the business aspects, the revenue billing cycle, the training and development of the staff, having an eye towards, it's kind of ridiculous to bring 12 trays into an OR for one case. If you can do some predictive modeling to determine the actual sizes that you're going to need and bring in only a handful instead. So we feel like it's a completely different role. At least that's what we're banking on, is that there is a need and benefit to someone like Dr. Bray having a positive connections representative that's more of a business solutions contact, and where you do have direct contact to someone like me and a team of people who will come in, study what you're doing, and apply the resources that we have to develop something if we don't have it. But if we have a solution, then to help you deploy that solution. That has little or nothing to do with the robot or the implants. Now, obviously, we're not an altruistic business. We feel like that builds a strong bond and relationship and a connection. When we care about your business in a different way, you'll be hopefully more connected to Smith & Nephew. So that's what we're doing. We will still have implant sales reps. That's an important job. They're necessary. They're needed. Surgeons rely on them. They might rely on them in a little different way, as Dr. Bray pointed out, in the future. But right now, still really critical to the outcomes for the patients and having the right products there and what have you. But the business issues for a surgeon are really looming, and we care about those things, and we've developed considerable amount of effort to solutions, and we'll continue to do that. We're invested. My team is huge, and I got here 2 years ago. There were 4 people that we called the ASC team, and by the end of the year, there'll be 100 people focused on just the ASC, or the outpatient center. As we've mentioned, it's bigger than just ambulatory. Even globally, this is a phenomenon, and they call it I think same day surgery.
Thank you.
I would have a couple of quick comments on Laura's one, just real fast, but I don't believe that the rep is being replaced. I think the role is shifting into more of an educator and integrating them more into the OR team rather than just selling to the surgeon. And as to the paper and the comments and the wording, I don't have a single surgeon who's written check for the implants to the company. Those are written by the structure. So that relationship is not, it's been ignored over the years, and it needs to be developed, because that's where the customer is, the ASC. The surgeon is being brought now into the loop and educated in that loop and now in the past, even years ago, I didn't know what an implant cost or how much my biologics were. I wasn't part of that. I just came in and said, I wanted to use this. Now we're part of the whole cycle. And as part owners in the ASCs and development of its process, really very aware of it and integrated into it. So it's changing that way.
Very good. Let me ask one final question in deference to our time, and that's directed at you, Dr. Bray. And so can you briefly explain how global payment contracts, which I think you stated was the majority of your reimbursement, have impacted DISC's evaluation of vendor products, expansion of payer contracts?
So we started a program here 2.5, 3 years ago. It was called Trias Global, and it has now crossed all the major vendors, most all of them. And it's about 70% of our billing and rapidly rising, and will be our total. And what it is we developed a package that looks at the entire event of care, including if we have to take them back to the OR. And we globalize that to one fee, the patient pays their co-payer deductible, and they are actually out of the billing cycle at that point. Our patients never receive a bill. The settlement is made between us and the insurance company. The insurers love it. It gets rid of all the bundling issues. It gets rid of immense amount of work on everybody's part, allows a much broader authorization and access to the cases. And the patients absolutely love it. They're insured. Thank you. Your co-payer deductible's paid. You're good. So as a part of that, it's the data analytics, and the same company does the data analytics and supplies the data back to the insurer. And via that, we can show them the cost savings that we have affected them on a case matched basis, and it's not insignificant. It's large numbers. So it's a looping of the quality, the data, the running and all the pieces together. And that's the type of information we need to work to share with the vendors so they figure out where they fit in this whole big project and where we fit with them. And it is about developing that relationship and the whole package and not just another implant, as Laura said so well. That is where it's going.
Okay, great. Thank you very much. So in the couple of minutes that we have left, I would just give each of the panelists the opportunity to make a final comment, maybe something that has popped up that you'd like to share with the group. Again, appreciate your participation, your preparation for this. Ryota, any final thoughts that you'd like to share with the group?
I think echoing a lot of what was discussed today, just the need to look a little bit deeper than just simply ambulatory risk hospital. I really love what Laura and Smith and Nephew are doing about kind of going into thinking about the various needs, and what Dr. Bray is mentioning about need to sit down with each ASC, because the needs for, say, a site like this where they've been doing this for decades versus those that are just starting out on their journey, they might even need help thinking through what they have not thought of yet. So companies like Smith and Nephew that have experience across the country could play a really good role in that, helping that transition become smoother.
Very good. Thank you. Kate?
Sure, and sort of piggybacking off of that, I think as you're sort of stratifying different markets, just different centers or different health systems that you're going to go to be working with, and kind of what their needs might be depending on where they are in that transition. I was definitely struck by a few different things. I know, Laura, you mentioned about positive connections and really kind of how you can be kind of that broader partner to those systems. Dr. Bray, you talked about value demonstration. That's one piece that on the provider side, a lot of organizations have a tremendous amount of trouble doing. So anything you can do to help kind of support that, be an educator, all of those things, I think is really gonna put you in a better position, and your partners as well.
Thank you, Kate. Laura, final thoughts?
I would just say the one topic that we didn't spend a whole lot of time on is around the digital health aspects and the data, the importance of data. And I would say that if you do a future program, you could spend a whole hour just on the changes that are occurring there, the resources that are available to outpatient centers and ambulatory surgery centers. It's going to play a key role, and it would be a key product, if you want to call it a product, but capturing the data, understanding your data, and then utilizing it to provide better care, but also to work with payers, to be able to state what your outcomes are. I can't underscore the importance of that going forward.
Very good. Dr. Bray, final thoughts?
I think we're facing a new future post-COVID in process procedures, how everything runs. And I think looping that information is important. And I think the one thing we didn't talk about that is another, again, could be a whole topic, is government relations. And I think that looping together the brain trust capability of things like SG2 and Smith Nephew and centers that have experience, and developing all this whole process we're talking about, and actually then taking it and helping control that flow for government relations, both at a state and federal level, could be a very valuable piece of where this whole thing is going. And we're the ones doing it. They're the ones developing the systems and the processes and put it together. We need to loop all that together, and we need to control it.
Okay, it sounds like we have a couple months worth of webinars. I personally would like to thank all the attendees from OMTech, as well as the panelists and the preparation that was put into this. It was exciting, informational content. And with that, Carolyn, I'll turn it back over to you.
Great. Thank you to our panel for such an excellent conversation. You've provided great insight, I think, on the future of the market, but importantly, how device companies really should think about their ASC strategy and partnering with centers and physicians. So thank you for sharing your time and your expertise. I also want to, again, thank TECOMET for sponsoring this webinar, and for those who attended, thank you. Again, this session will be available next week on demand on the OMTech website. And a quick reminder that you can access all of the webinars from our virtual education series at omtechexpo.com. So thank you so much, and I hope you have a great day.